All right, everybody. Welcome back after the coffee break. And may I invite our next speaker, Matt Goss, who will be talking about creation of the Ukrainian medical physics training course and its potential for transferability and scalability to sites in Africa. Thank you.
Thank you very much. Good afternoon, everybody. Again, I'm going to say what everyone else has said, which thank you so much to G-Haas and Radiating Hope and the whole administrative team for including me in this. I've been involved with Radiating Hope and on the board of trustees for a number of years, and I've never been to a G-Haas before. So this is my first one and my first time in South Africa, and I'm really grateful and thankful to be a part of it. So what I'm going to be talking about today, I have no financial disclosures, nothing relevant. Today we're going to be talking about a project that was done over the last year in coordination with a bunch of different groups, notably the AAPM, the American Association of Physicists in Medicine, and a nonprofit called the Help Ukraine Group. I'm going to talk about how it was built, the timeline, the foundation of it, the creation of the actual program itself, and the implementation. The outcomes, we just recently got the outcomes and what we were starting to learn from this project, and then future direction specifically about that project. But why would I talk about something that's happening 8,000 kilometers from here, right? This is an African conference. We're talking about what's happening in Africa. I want to make sure that we can take some of the lessons that we've learned and see what we can do in other markets, other places in the world, specifically sub-Saharan Africa. So it's also, there's been a lot of other interest for other LMICs. So can we take some of the lessons we've learned and scale and transfer them to other places? And then if we do that, can we create a working roadmap that can then be used in further places? So I'm going to start off by kind of a personal connection. This is my wife and I on our honeymoon, and we traveled all through Eastern Europe, and I like to joke that I'm the only person, this is a very physicist kind of thing, but I took my wife to Ukraine, and we actually went to Chernobyl, so I'm like the only person who's dumb enough to take their spouse to Chernobyl on their honeymoon. But the physicists in here are probably like, that's so cool. And it was great. It was really cool. But we went to Kyiv. We had some friends of friends there, and we ended up falling in love with it. We really had a wonderful time. We met some incredibly warm people, very, very kind. We loved the culture and the food and everything about it. We had a wonderful, wonderful time, and we're really impressed with the people. And of course, this was kind of right before, this is 2018, this is right before the kind of escalation and the conflict happened. So we kind of already had, or I personally had kind of an ethical involvement anyway. We kind of knew people, we knew what the country was like and the hardships they were facing. So when the war started, and it kind of went to the next level, it was something that was already on my mind. But what had happened is I was involved with a different project first. So at my institution, which is in Pittsburgh, Pennsylvania, by the way, it's about halfway between New York and Chicago if you drew a straight line there. We have a physician who's Ukrainian, and he wanted to send medical supplies. So he got the medical supplies donated, but he couldn't really figure out how to ship it. So in 2022, I talked to Tom and the folks at Radiating Hope and said, can we ship something to Ukraine? And he said, yes. So we ended up kind of partnering together, and we got some funding from this other group called Brothers Foundation, and we decided to ship this stuff to Ukraine. And we did so by getting involved. I kind of pitched the idea of a domestic climb. We saw Brandon give the talk about how Radiating Hope came to be, and we had some fundraising and things like that, but we'd never done a domestic trip like this. So I pitched the idea of doing a domestic trip in the US, a climbing trip, and funneling that money into this project, and we did. We went to Mount Baker. This is me on top of Mount Baker out in Washington State. It was wonderful. We ended up sending 72 pallets of pharmaceuticals and medical equipment to Ukraine. It went from JFK in New York City to Poland and then overland to Ukraine and ended up in the hospitals. It was a success. It was wonderful. So in 2023, the National Medical University in Kyiv had heard that we had done this, and we'd already kind of dealt with the Ministry of Health. So they asked, we really need a linear accelerator. We're starting to see some of the areas in eastern Ukraine that have largely cobalt machines. They're getting taken over. We don't really have the access to this anymore. We need to kind of modernize anyway. Can we get a machine? And I said, well, I work with an organization that does exactly that. So we partnered up. My institution and Electa also got involved, and we kind of evaluated their existing cancer program. They gave us kind of what they had in terms of a bunker, and Tom and his team found a Linac, so a Versa HD from Bismarck, North Dakota, and it was being decommissioned. We got some local press out of this. It was very cool, and ended up getting it consolidated in the Carolinas, and then sent. Radiating Hope helped with the logistics, shipping, and again sent it over there. Elect has been involved with organizing the install and training. And then my group in Pittsburgh and RCC, which is Rayos Contra Cancer, was mentioned again before, another great group, have decided we would take on the teaching and training once it gets there. So this stuff arrived actually in May of this year, and you can see the Linac in boxes and various, like many boxes. And that's them accepting it, and they were really happy, and it was this wonderful success again. So we actually did another fundraising climb. The first one was a success, so I did another one to Mount Hood, which is in Oregon, outside Portland, Oregon. We did that this year, and we raised even more money. So we're actually waiting right now for the bunker to be retrofitted, and we're going to hopefully be able to do some teaching and training. But that kind of brought us to the next thing. So, and by the way, that's all we got. They said, here's our bunker. Like, what does that mean, right? So as a physicist, this is terrifying because you're like, I have no idea, like, what is it made of, and what are the thicknesses, and whatever. So this is the kind of stuff we deal with, but we do the best we can. So anyway, after that happened, the bigger project kind of started, which was that since I was already involved with this stuff in Ukraine, the American Association of Physicists in Medicine ended up receiving a request through what's called the Needs Assessment Committee, which is how they kind of bring in all the requests from all over the world and decide how we can parse resources out. So a woman named Natalia Kovalchuk, who's a faculty at Stanford, she's a physicist, but she's also Ukrainian. She had started a nonprofit called the Help Ukraine Group to help place people whose education had been disrupted by the war, collect money, donated stuff. It's incredible what she does. But they went to the AAPM and said, well, there's a lot of physicists in Ukraine, but we need a lot more. There's not enough machines. Some are being bought by the government, but nobody really knows how to systematically accept them and treat with them, and best practice development, things like this. Could AAPM help with this? Now, because I'd already been involved with this other stuff, I was kind of tasked with this idea. And if I had known what I was getting myself into, I'm not sure that I would have, but I did. I said yes. I got involved. And so we decided we would build this 3-part series of educational programs for the Help Ukraine group and basically the physicists in Ukraine. So the first they wanted was machine acceptance and commissioning. The second was external beam planning. And the third was QA program development. I said, okay, so what do we do? What do you do when you have to build a program like this from the ground up? Well, the first thing we did is we said, okay, well, who do we know? Who do we know that's good at this stuff? Could we get some lecturers, find some good people to do this? Volunteer database, AAPM, colleagues, people, friends of friends, whatever. So we went through all this and we kind of assumed that, well, we want people that are good at a lot of different things, or should we get people that are just good at this one thing and whatever, and we kind of did both. We would like people that were already volunteers or good at teaching or heavily involved anyway. Then we kind of went and identified a curriculum. We started to work backwards. We said, okay, well, what would be the things that I would want to know? And then who's good at that thing? And then we kind of plug them in. So we said we're going to have 2 or 3 people per topic. We're going to have leads and backups and things. We're going to have to figure out how impactful this is. So to do that, you have to measure how good people or how competent people were before and how competent they are after your program. And then you can kind of go back. To do that, we had to create kind of a questionnaire and say, okay, well, like everything from what kind of machines do you have, or how much experience do you have, or what's your language proficiency, what kind of water tank do you have, et cetera, et cetera. And then we could use that to go back and then re-identify, do we have to change our curriculum in turn? So then we can measure outcomes. We made a post-exam and a pre-exam and kind of measure the difference between the two. So here's the questionnaire. I'm not sure I don't have a mouse here, so, okay, so you can kind of scroll down. Everything was in Ukrainian and English. We gave this to every person in the country, literally every practicing physicist in the country. You can kind of scroll down. It's everything from, is it private, at public? How many patients do you have? How many doctors and RTTs? What's your planning system, et cetera, et cetera. You get the idea. This goes on and on and on, but it ended up being very, very useful because not only did it help us develop the curriculum, we could take this and then the answers from this go right to the Needs Assessment Committee and the Equipment Donation Program at the AAPM, and they can use this to actually funnel physical donations that are maybe too big for Radiating Hope or different kind of Radiating Hope, and then they can do that. So you can go back to the slides. Thank you. Okay. Oh, I was like, what did I do wrong? Oh no. So anyway, so we decided to implement this. So what are the opportunities and challenges we had? Luckily, as we started to build this out, the idea was originally to have like 6 lectures per thing. So we're like, all right, 18 lectures, we can manage that, fine. But then they said, well, we're doing this kind of like practical part, but we really need some like didactic beam physics and physicsy stuff. And we're like, well, that sounds an awful lot like an entire graduate program. I'm not sure we could do it, but luckily Stephen Avery, who's at University of Pennsylvania, had already given a course exactly like that the year before to Nigeria. And it was a rousing success. It was very, very good. So we kind of called Stephen Avery and said, hey, would you mind doing that again with the same people that you did it last time? And we'll kind of dovetail it with what we're doing. And luckily he was really great with that. So we said, okay, we have some stuff built, we're good. We sent out the questionnaire. There's 100 practicing physicists in all of Ukraine, and 131 people signed up. So literally every person who's a physicist in Ukraine and a whole bunch of students and other support staff signed up for our course. We got a learning management system, which was basically a Zoom or a FaceTime type of interface, but it had real-time translation. It had moderators. We got people who spoke Ukrainian and English. We got, everyone was giving their lectures in English. How do you translate that, and most of the people taking it only speak Ukrainian and not English, so we had this language barrier to deal with. We recorded it, we posted the lectures, we ended up having that translated by AI, and then someone physically go back through each one and make sure they were edited the right way. And that's kind of what it looked like. That's Rob Krause up there, who was one of our fantastic speakers. We ended up applying for CAMPEP accreditation, which is the medical physics training program, kind of accreditation body in the US. That was a really big deal, so we got credits for it. So the idea was Stephen Avery was going to give his lectures on Saturday, or his folks were going to give his lectures on a Saturday, and we were going to give ours on a Wednesday. And we were going to do that in tandem for quite a long time. So he did his didactic, we did ours on Wednesdays as practical. Started in mid-January, so like this was requested in the fall, had to start in February. So we had very little time to build this program, and we did. So we started acceptance and commissioning February, and the idea was to do it till early May. And then the QA treatment, or the treatment planning and QA program development, we kind of went into kind of became the same part, so we just called that part 2. And the idea was to finish up by mid-July. And the only way we were able to do that is after Stephen Avery's course was done, I said, okay, we can take a break. I'm only managing 1 a week. And Natalia said, well, everyone's really used to 2 a week. Can you just do it twice as fast? So we said, you don't want to say no to this. So we said, yeah, and we ended up deciding we're going to try to finish by AAPM, which happened in July. And we came in with 1 day to spare. So we actually delivered on this, and we did it incredibly quickly, and what I think of is at a very high level. So we had to give questions, and 5 questions embedded in each lecture, and then they had to answer 5 questions after that. This is what all the slides looked like. It was very high level, very well done, very well curated. And this is what our curriculum looked like for the first part. So this part here you can kind of see, this was Stephen Avery's, all of his topics and all of his dates. These are Saturdays. Here's the people that gave them. And then this was mine, and then it happened on Wednesdays, and these are what we did, and this is the people that gave them. And for the physicists in the room, you're gonna notice some heavy hitters on this list. There's some fantastic people who gave these talks. I saw Saiful Hook on one of the other ones before. Saiful literally wrote the book on absolute calibration. He gave a bunch of these lectures on absolute calibration. It's like literally the people who wrote the book here. Same thing we had, you can kind of go through all this stuff, but there was stuff on ethics and SBRT and Breaky, and it kind of grew and grew and grew, and what was originally a 6-part course turned into like a 12-part course per thing. It just grew and grew and grew. And then that was what the curriculum looked like that we gave out to the students, kind of the Saturdays and the Wednesdays all together. And then we did the second part, which was treatment planning, took a break, and then we kind of did this QA program development. But we did everything with FMEA. Eric Ford gave FMEA. He literally is the FMEA guy, like Susan Richardson, Rock Mackey, like on algorithms. Like these are like the best people in the US that kind of develop these topics, giving these lectures. Incredibly busy people, but they did it, and they did a wonderful job, and we were so thankful to have them involved. So what did we learn from this? So as I said, 131 signed up. 80 finished the course, which when you think about, I mean, there were people whose hospitals were destroyed during the thing. They were missile strikes, constant outages of power, people getting conscripted, people disappearing. Like that happened throughout our course. So the fact that 80 people finished this is actually pretty remarkable. At the beginning of part 1, the pre-assessment, 52 passed it. Afterwards, 83 passed it. For part 2, 70% passed the pre-treatment assessment, 90% passed the post-treatment assessment, and we ended up awarding 76 certificates, which means that there's 4 people we're actually still retesting, basically, to make sure that they kind of got it all, and the idea is to eventually award 80 for the people who sat through all of these lectures. We ended up doing 50 lectures, It was about 90 hours worth of just recorded material, but if you account the pre-reading and all the testing and whatever, it was like well over 200 hours of work for each of these people to do while they're in the clinic, during a war, in their, it was really remarkable that they stuck with it. They did a really, really good job. So the final part to this, and what's going to be the most challenging, is that we decided that we needed a hands-on component to this. We can teach them how to do this and say how to do this, but they need to be able to physically set up the water tank and do beam scanning and modeling and these things. So how do you do that? Again, so far away, in the middle of a war, none of us can travel there. So we decided we were going to do a hands-on third part to this, and we would manage it by dividing them up using that assessment that we gave. So we said, okay, all the people that are Electa users will go to this hospital that's an Electa hospital, and all these people who are Varian users will go here. We have some people on the ground who took parts 1 and 2. The prerequisite is that everybody who signs up for this had to take parts 1 and 2. And then we were gonna have them go through these examples and these 3-day clinical workshops together. So we had one hospital is in Lviv, one's in Kiev. We have a 3-day course. We're gonna do it 2 times, one for each vendor. The curriculum looks like this. I'm not sure if you can see, but it's everything from treatment planning to QA program development, beam modeling, setting up your QA program, things like that. So very practical, actual physical hands-on stuff. And also building on the stuff that we taught in parts 1 and 2, obviously. So the idea here, and I think we've learned this in the volunteer space, anyone who's been involved with this kind of thing understands that the idea of going somewhere and doing a thing and showing people how to do it and then leaving does not work. There has to be constant engagement, there has to be constant checking back in, and just giving your knowledge to someone or some group is not enough. There has to be a lot of engagement, buy-in, back and forth. You have to constantly be reinforcing it, checking up on it, and then the idea is eventually they become the trainers for the next generation of people, and it's regionally sustainable. So we kind of worked on this. We said, okay, we're gonna start with this assessment, we're gonna create the program, and we're gonna execute it, evaluate it, and learn from it, and we're gonna make changes, and we're gonna go back and kind of feed that back into the assessment for the next one. So we started doing that. And we said, well, can Ukraine, if they really get proficient at this, could Ukraine end up being kind of a regional hub? And I'm not talking, I mean, who knows what's gonna happen politically, but they have a knowledge base now. There's 100 people that have a much better knowledge base of medical physics and clinical implementation than they did a year ago. What happens, what about the regional, area? Can we get people to eventually go to Ukraine, and Ukraine's the training model, is the hub of that training model? And that's what we were hoping. So again, why am I talking about this here? Because I think there's so many parallels that we could use between the Ukraine, access to care, access to education. We can use that stuff here, or other markets as well, to kind of see, we already built this program. Can we scale it? Can we transfer it here? I understand that Radiating Hope especially, we do a wonderful job with physical machine donation and physical equipment donation, and that's massively important, and we have a lot of work to do left. There's not enough. I think everyone in this conference can agree what we've learned is there needs to be more access to care, to physical stuff. But that coming along with that is we need the people to be able to use that equipment effectively and safely. There needs to be a robust training program that is scalable, and we don't want to reinvent the wheel every time we do that and go to a different country. So the idea is, there's differences though. It's not just as simple as taking this thing, and we're not going to give the exact same talk or series of lectures from Ukrainian to, a different country, let's say sub-Saharan African country. There's cultural barriers, there's differences, there's infrastructure differences and challenges, obviously, language barriers, funding, finance, donation barriers. Look, I'll be honest, Ukraine got a lot of attention in the press, it got a lot of outpouring of funding. Just because it's not in the press doesn't mean it doesn't desperately need funding, so there's other countries that are, poorly represented in the media that maybe don't have access to it. So what's the way forward? Well, the idea is we're gonna kind of build this roadmap. So the initial phase, which we'll call Ukraine, we kind of created it, implemented it, we got these expert people, these volunteers, and they taught the participants. We didn't say students, we always said participants, by the way. And we assessed their competency, and we got these sign-offs and credentialing. The next idea is the secondary phases, maybe that's within Ukraine. Maybe they become, we rework the curriculum based on what we found, we implement it again, and the first cohort of people who participated become kind of the trainers with some oversight. And then we do another set of credentialing and acceptance of kind of their knowledge base and things like that. And then finally, the ongoing phase is not that we completely step away, but we kind of help them build that program, and it becomes a little bit bigger regionally. So there's no reason that we couldn't do something like that in sub-Saharan Africa, where you end up with a hospital. It doesn't have to be a whole country, but maybe one center or one group of centers that becomes a regional training hub. We go through this model, we end up making it a little bit bigger, and it becomes, that country becomes kind of a well-established training area, and then it goes to other countries in the region. That region could be the Greater Horn, absolutely. So, what we learn, every time we do it, we build on it, it kind of becomes bigger and bigger. So conclusions here. There's obviously an acute need for training in LMICs. We know that, that's why we're all here, right? The training programs can be created, but I think one of the other talks here, there's been a few that we kind of see that there's some of this stuff happening in parallel. We need more communication between NGOs and other groups to make sure we're not reinventing the wheel here. We can use them. Instead of competing with them, we can use what they've done and kind of learn and go from there. It can be impactful, it can be very measurable and scalable, it can be transferable. And the ability to overcome kind of barriers, it is there. So even though they don't speak the same language, or even though the training is different, or there's an ongoing conflict, that doesn't mean we can't make an impact. It's challenging, but it's not impossible. So the AAPM is interested in adopting this model from the Global Education Training Committee and the Clinical Education Working Group, International Council, to new requests. And then the partnership with clinical groups, educators, participants, NGOs, governments, and individuals on LMICs is critical to make this stuff happen. Here's my contact information. Here's some of the stuff as Brandon alluded to, I did some climbing and hiking. Here's the prayer flags and things like that. But please feel free to contact me and reach out. We are really interested in your perspectives on this and how we can help build programs for you. Thank you.
Thank you, Matt, for that burst of energy for the home stretch here. So this next panel is something I look forward to every GHAS, and it's really an update about, we're going to go back to the Greater Horn, basically. So I'm going to invite Dr. Kavuma Awusi to talk about radiotherapy in Uganda. If Dr. Beda Likonda can also come up to give us an update about cancer care at Bugando Medical Center. And then Dr. Furaha, Dr. Furaha Serventi, to talk about Foundations for Cancer Care in Tanzania. And this is, for those of you who've been at GHAS for the past 10 years, you will see how things have changed, and that's why I look forward to this every year. So I'll let these guys bring it in. Go ahead, please.
Thank you so much. Just take you a little bit to the history. Sometimes they say it's not easy to understand where you are if you don't appreciate where you came from. Uganda is a landlocked country with a population of about 46 million. And annually, we receive about 700 new cancer patients. We have one radiotherapy center. Most of our patients are diagnosed with relatively advanced cancers. In the 1980s and 90s, there was scarcity of radiotherapy in most African countries, and only 23 out of 52 countries had EBRT. But Uganda distinguished itself as one of the pioneer African nations country to initiate radiotherapy, and it started in 1989. Since the inception of radiotherapy, efforts have been there to expand services, but we are faced with numerous challenges. However, the past 3 to 5 years have witnessed some significant transformation. That was the first Cobalt-60 machine, a Siemens Gamatron, commissioned in 1988, and it was installed in one of the centers in North African Uganda. Permanently closed in 1994 due to insurgencies in northern Uganda. So that was the second machine, a stable pan-ortho voltage, installed in 1989, and it was housed in the same building as the first inaugural X-ray machine unit, X-ray department unit. So in this same department, that's where initially it was modified to install the first MV radiotherapy bunker to install the first cobalt-60 unit. And that was the first cobalt-60 unit manufactured by a Chinese company, and it was installed in 1995. The first 1 to 2 years of its operations, we treated about 1,000 new patients. The gender distribution was 1 to 2, male to female. This is because most of our patients are cervical cancer and breasts, which accounts for the high incidence of the high numbers of females compared to the gentlemen. That was the first brachytherapy unit, a cervix 6 low dose rate unit. It was commissioned in 1994. It had a dose rate of about 2.5 grays per hour, and we could only treat about 1 patient a day, a maximum of 2 patients, because of its low dose rate. And we decommissioned this unit in 2015 after treating about 6,000 patients. This was the time when we have a crisis in Uganda, when our only cobalt machines broke down, but it treated about over 20,000 patients over its 20-year period. And people were saying whether it was broken machines or the broken system, but I think it was more of broken system than the machine. We restored the radiotherapy services in 2017, and it was a renewed hope for cancer patients as we commissioned a new Terrabolt 80. We got another donation in November 2019, and this really came as a boost to help our patients. The same year, we began the construction of 6 bunkers, including 4 Linacs and brachytherapy units. And March 21, we commissioned the first Linac, and also the same time, that's when we started 3D conformal radiotherapy, a leap from 2D to 3D. In March 2022, we treated our first IMRT patient, now on a TrueBeam, and a collaborative effort with the team from the Washington Unity, a collaborative effort from the radiation oncology team from the Washington University, which helped us with the training and the setting up the QAs. A year later, we started VMAT, and in August last year, we treated our first VMAT patient. Collaborative efforts with the Washington U, and the same year we implemented the SIB photodosimetry. We commissioned it the same year. UCI, our center, pioneered in Africa the use of auto-segmentation since August 2022, and actually 100% of our patients now we are using auto-segmentation. We made some publications. Auto-segmentation has reduced time required for the organs at risk contouring from about 70 minutes to 2 minutes per case, saving thousands of hours of radiation oncology time. Recently, in August last year, we added on 2 additional Linacs, CT SIM, 2 brachytherapy units, C-arms, all of these to improve patients' treatments. And these additional installations have enabled that right now we are treating about 200 to 40 patients per day. We are doing about 18 cervical insertions, 8 to 12 daily CT simulations. Generally, more patients are accessing treatment, reducing waiting time. We have acquired a rapid plan for research. Auto-planning has been in use in high-income countries for years, but limited in our countries. The major hindering has been really training of the models. So we did some study, and as you can see from also Professor Lawrence indicated it, you can't easily differentiate the difference between the manual and the automated plan. We did some studies still before we did this work. I will rush through all of this. And we have made also publications. We are happy to move on with planning, and we think that the integration of auto-segmentation with auto-plan will speed up radiotherapy clinical workflow further. Currently, we have 5 EBRT units and 3 HDRI units compared to 1, so we are treating a lot more patients. And 50% of our patients and 50% of EBRT are now treated with IGRT compared to none in 2020. We have had challenges, of course, the breakdown, the bank constructions. Installation is always a challenge. And in the future, we are looking at all of these new technologies, SBRT. Despite the advantages, radiotherapy access remain limited. We see that most of our patients whom we treat are coming from the central. So the government is planning to expand by introducing new centers in the northern parts of the country. There has been several reasons which we have learned, but the major ones include collaborations, strategic planning, the specifications, among others. Thank you so much.
Yeah, good afternoon, everyone. I am Dr. Beda Likonda. I'm working as a radiation oncologist in the Bugando, which serves a population in the northern zone of Tanzania. As you can see, this is our center, and you can see around the Lake Victoria, that is where we have a catchment area of almost 22 million people out of 62 million Tanzanian, and it's about 1/3 of the total population. Actually, prevention activities are going on at the center, at the same time in the community through non-governmental organizations, and where immunization programs against the human papillomavirus and the HPV is still going on, screening for cervical, breast, and prostate. And in our center, it's about 1,000 women undergoes screening per year. Yeah. So over the past almost 7 years, as you can see, the patients we are receiving at the center is only about 10% of what we expected. In a country where we have new incidences of around 45,000, so we do expect 1/3 of the incidents will be coming from our area, which is around 15,000. However, we have about 10% of patients reaching the center. Yeah, so you can see the incidences for both males and females. Prostate cancer is leading, followed by lymphoma, and the GI for males, and for females we have cervical cancer and the breast, and the lymphomas also. We have a pathology lab which have 7 pathologists and 2 hematologists, and they process about 7,000 samples and 3,000 cytological specimens per year, and on average 65% of them turns to be neoplasms, and they also perform H&A and the special stains and the immunohistochemistry with a number of 31 different antibodies and the blood counts, biochemistry, tumor markers, and the malignance. We have also a training course for pathology. We also have an imaging department, which have both CT scan and MRI, and also we have SPECT, where we perform different nuclear medicine procedures, as you can see. Then we have a radiation oncology unit, where we have 1 cobalt, 60 teletherapy, 1 cobalt, 60 HDR afterloader, brachytherapy suite plus a CM, 2D planning. About 80 to 100 patients are treated on the external beam, and about 3 to 5 HDR brachytherapy cases are treated on a daily basis. However, we have 4 empty bunkers, which has been shielded for 15 mega voltage equipment. So in 2023, we retrospectively analyzed our data on the patients who have received treatment in our radiotherapy department. As you can see, most leading cases are cervical cancer, which is about 53%, then followed by head and neck, and then we have breast and prostate, and the rest. So, this. So we have, as we can see, we also have patients on brachytherapy, about 40 patients per month, new cases, and we have some months where we don't perform any cases. This most of the times because the machines, sometimes it is down, so we fail to do cases in some other months. And this one has an impact. As you can see, analysis of our patients, we have about 70% of our patients on stage 1 and 2. As you can see, the time spent for external beam radiation therapy were good, but when patients are transitioning from external beam radiation therapy to brachytherapy, there is a lot of delays because of the machine breakdown due to sometimes failure of the preventive maintenance on time. So we have, as we can see, in our patients, we have about 20% of them having insurance, and the rest are not insured. We also provide the systemic therapy on daily basis as a daycare, and also we have patients who are being treated in the wards if they are being hospitalized, and we have a total of 700 treatments per month. So in our systemic therapy unity, we have about 70% of our patients are female. This is because of the concurrent chemo radiation therapy with cisplatin for cervical cancer patients, and also breast. And as you can see, that the most commonly used chemotherapies, the platinums, and the taxanes. And we don't have antibodies or immunotherapy at the moment. In the society, we also have collaborations and networking for palliative care, where we follow our patients to their community. However, this program is not well established. So challenges which we are coming across our services, which we have made difficulty for us to do transition and also to maintain our services. One is a country cancer care policy, and I'm saying this because there will be the third center which will be established by in Kilimanjaro. So there are things which I think also they need to see how to take care of this. One is the cancer care policy, where if patients is not insured in Tanzania, they have to be treated for free. And also the insurances, especially national health insurance policy, does not allow institutions to set their own prices for durability and the maintenance of the equipment. However, the prices are being set by the National Health Insurance Fund. Most of our hospitals, they are not cancer care dedicated. So hospital management, they might have some other priorities. Suboptimal healthy technologies, as we can see, we are still doing 2D, and in our labs, we don't have molecular diagnosis. And the last is inadequate funding across education, immunization programs, screening, labs, imaging, palliative, training, research, and development. And for this, we invite for more collaboration and networking to improve cancer care in the Lake Zone. Thank you.
Yeah, I'm Furaha Serventi, and I'm going to discuss about Foundation for Cancer Care in Tanzania. I'll briefly rush through this because most of what is being covered is within the slides, and most of the experiences have been shared, and it's similar experiences across Africa. Okay. Right, yeah. Okay. I'll discuss briefly on Foundation for Cancer Care in Tanzania, which is a non-governmental organization from the United States in Minnesota, which has partnered with Kilimanjaro Christian Medical Center in the northern zone of Tanzania to establish cancer services within that zone. The partnership started in 2013, and it was due to the response to the large number of cancers being diagnosed at the center through imaging services which were developed by the East African Medical Assistance Foundation. The Foundation for Cancer Care in Tanzania enhances cancer care to improve the lives of the citizens in Tanzania through education programs, prevention and screening programs, and services providing treatment and palliative care. It consists of board members, of which are enlisted, and so I'm representing the board members as of now, and presenting the work they've accomplished with us. So these are the 4 pillars, and these are how FCCT, together with KCMC, categorize its efforts, and we are working on all 4 and have been doing so since our inception. So obviously those in the audience will know where Tanzania is, but from outside of Tanzania, those who are outside from Tanzania may not be familiar with where, for example, Mwanza, Dr. Beda has shown in the previous slides, but also Kilimanjaro regions are. So we are on the yellow highlighted area, and we serve a population of 15 million people in the northern zone. This is the first efforts from FCCT, which funded the cancer clinic and infusion, and the services were opened in 2016. FCCT provided funds for the initial purchase of chemotherapy drugs and hood for chemotherapy mixing. We then, FCCT and KCMC, established an inpatient cancer ward with 44-bed capacity. And this allows for more specialized nursing care, separation from general hospital population, thus reducing infection risk. So the ward includes also 4 isolation rooms with HEPA-filtered air. So ultimately, we want to be comprehensive, and we are establishing, together with FCCT, a construction. We are constructing through the government of Tanzania, funding the construction, but also through a grant we had, which was awarded to FCCT from the USAID. USAID further granted FCCT and KCMC a state-of-the-art true beam, which is already ordered, and we hope to receive it by January this year. Other equipment such as brachytherapy, a brachytherapy unit, Iridium 192, a CT simulator, and software, and these are all covered by both FCCT, KCMC, and the government of Tanzania. Radiating Hope is donating immobilization devices, applicators, and other equipment which are needed for the center. And we have the shipping, which is already in the country, and hopefully we'll have it by this month. A container full of immobilization devices. Just to tell you about the costing of some of these, we had calculated, at least for the QA dosimetry and immobilization devices, it comes to $300,000. So that's quite significant. And so Radiating Hope have alleviated a lot of this. Yeah. So yeah, Tom Ladd, as we were discussing, just advised me to pitch this list to you in the audience. This is our dosimetry and QA equipment needs. And so we certainly need this a lot to be able to comprehensively QA and be able to carry on dosimetry. So hopefully we'll continue communicating, and so for those centers who might be ordering some new equipment for QA and dosimetry, if you can pitch in maybe an extra equipment for KCMC, that will be highly appreciated. Yeah. So not only have FCCT and KCMC invested in infrastructure and equipment, but we know the role of professionals. And so there's been a lot of investment which has been taken to educate professionals. We've educated the list, a pediatric oncologist, clinical radiation oncologist, hematologist. We are a very comprehensive team of more than 70. We started with 5 people, and we are now 70 people with 8 specialists in the center. So these are some of the projects we are doing with FCCT, and obviously with 70 to 80% of cancer patients presenting late, palliative care has been critical service. So we've also ventured into research activity, and we've partnered with Oxford University and like Mayo Clinic, University of Minnesota, and also some of the Dutch universities, Radboud and Princess Maxima for the children, and some prevention campaign research is ongoing. Professional development has gone on as well. We have monthly tumor boards with FCCT's members from University of Minnesota to discuss on the most complex cases. So the path forward, there's training which is needed, satellite clinics and research capacity is to be enhanced. So these are just a summary. I know it's a busy slide, but it reflects the many ways FCCT and KCMC are partnering to develop a comprehensive cancer center and cancer services, providing cancer services to the people of Tanzania and East Africa. So, and ultimately, we have we are actually planning an international conference, and you'll just find it in www.kcmcicc.com. So the window period for registration will be open at the end of the month. So you are all welcome to the northern zone of Tanzania and Kilimanjaro Christian Medical Center. So this is what Mark Jacobson, who was a former boarder, he's late, he passed away of cancer, but this is what he liked to say to encourage the board, and again, emphasizing the partnership of FCT and KCMC in these efforts. And to be honest, these are some of the words and some of the feelings of patients we serve on a daily basis. This is what they wish. Yeah, they wish for a miracle, and we are providing that miracle, all of us. Thank you.
So I know we're a few minutes over. I can wrap things up if you all would like to take questions to the panel afterwards. Would that be okay, or would you want to do some questions now? I can't see in the back there because of the light. Okay.
Let's see if there's any questions now.
Okay. Any questions for our panel? Okay. Thank you all so much. Okay, so I think it's been a pretty fantastic 2 days. I hope you all have enjoyed the talks as much as I have. I think it's been very refreshing and just amazing to see all the discussions that have taken place between folks from South Africa, East Africa, somewhere else in Africa, and everywhere else in the States and the Netherlands and the UK. So really, thank you. I know a number of people have asked about presentations. We will have PDFs from those speakers who are okay with distributing them. So once we communicate with the speakers, we'll send that all out. The picture also, I'll be emailing Luca, just FYI. Okay. And really just a few more things. Just thanks again to Deb and Linda who put all of this together for us in terms of all the logistics. Tom, Asim, Aggie, you guys have been absolutely fantastic. The Access to Care team, Cape Town, or Access to Care Cape Town team, I see there. So Jeanette, Hester, I think Nanette, and Elaine, thank you again. And really just, and really the biggest thanks to you all for making this meeting so amazing. So safe travels, everyone, and it was absolutely wonderful to see you all here. Thank you.
We have
up for your meditation room.